Thank you, Julian. Good morning, everybody. I like to call this talk my wish list. These are the things that I'm most excited about that are coming down the pike in the next 5 years, hopefully less. It's a big topic, and I was given 15 minutes to cover it, so we're not going to cover everything that potentially falls into the category of intraoperative adjuncts. We just heard a great talk about cortical and subcortical motor mapping. So I like to think of intraoperative adjuncts in 3 categories. I think of them as the planning and mapping, then the intraop visualization and tissue differentiation bucket, and then the therapy bucket. We're going to spend most of our time in these latter 2. So we heard about cortical mapping. We're not going to have time to talk about awake craniotomies, especially for speech mapping. And then we could spend an hour talking about FMR and DTI and some of the advances there. So very briefly, just a quick overview, some of what we heard about already in terms of adjuncts to preserve functional anatomy. So neuronavigation, pretty much standard of care. It's great for minimizing our surgical exposure. It's great for making sure that our surgical approach does not traverse fascicles or pathways that we don't want to transect, and that we stay on target. It is static, as we all know. It can't compensate very well for brain shift during surgery. And oftentimes, up until recently, with most of the commercially available applications, DTI analysis is very hindered by edema. There are some products on the market that can compensate for this. Awake surgery and cortical mapping, primarily used in motor areas, dominant hemisphere, near language. We heard the benefits of maximum safe resection in terms of progression-free and overall survival. I would like to think that most patients can tolerate awake craniotomies, but we've all had patients that we know it's not going to go well, and we don't even try. It does require an entire team that's trained well in terms of logistics and equipment and having good neurophysiology techs, neurophysiology physicians. And then same is true more so for high-frequency subcortical mapping. But let's talk more about visualizing tumor tissue. And does anybody in the room know who this guy is? Damadian, right? Ray Damadian, the inventor of MRI. So I'm a big history trivia buff. So someday we'll have a little trivia night here at SSG. So kind of current state, 2 major buckets, intraoperative MRI and intraoperative ultrasound. These are macroscopic visualization technologies. Intraoperative MRI has been around for 25 plus years. It's great for deep-seated lesions. It's great for low-grade, non-enhancing lesions or recurrent tumors with irregular borders. There's been a lot of publications demonstrating improved extent of resection, especially for low and intermediate flare-only type gliomas. But this is incredibly expensive. It's incredibly disruptive to the workflow, and it's limited availability. And as much as we would all like to have one, the reality is that the headwinds financially and the headwinds logistically really preclude this from being widely distributed beyond major research academic medical centers. Intraoperative ultrasound, on the other hand, is a little bit more widely distributed. I think it's a technique that is grown in popularity, but still remains somewhat a mysterious black box to many surgeons because they're just not comfortable with interpreting the images in real time. But this is great. I use it on pretty much every cortical tumor case. It provides real-time feedback on extent of resection. It tolerates and compensates for brain shift. Some of the more advanced imaging suites will do real-time Doppler analysis if you're looking for regional blood flow and blood volumes. As I mentioned, there is a learning curve. There is lower resolution than MR, and it is very user-dependent. So sometimes people will construct teams where you'll have a radiologist or a radiology tech in the OR. Other times it's just the surgeon on their own. These do integrate with some of the navigation units, which can help overcome some of the learning curve of figuring out exactly what you're looking at and in what orientation. This is where things start to get exciting for me, because everything we've talked about is been there, done that. Fluorescent agents for tumor visualization. There are 3 that are either on the market or near to market. The 3 main ones are 5-ALA, which is marketed in the US as Gleolan, sodium fluorescein, and then tumor paint, which is a conjugate chelating chlorotoxin and IC green. So 5-ALA, really good for high-grade glioma. Lots of data from Stumer in Europe starting in the early to mid-2000s showing that it's really good for identifying enhancing tissue. It really doesn't work well for low-grade gliomas, primarily because it does not cross undisrupted blood-brain barrier very well, and it does require a specialized optics package for your microscope. Sodium fluorescein, super cheap. This is a blood pool agent, so it works anywhere where the blood-brain barrier is disrupted or doesn't exist. This is an interstitial agent. It has broader applications in medicine, but it's non-specific uptake in tumor. It's just telling you anywhere where there isn't a blood-brain barrier. And if you look in that middle figure, those are equivalent intraop images where you can very clearly see well-demarcated tumor with 5-ALA. You can still see it with the fluorescein, but as this case goes on and your resection goes on, the brain gets beat up, it starts bleeding a little bit, you get a washout, and you lose your margin. The Blaze 100 molecule is interesting. As I mentioned, it's chlorotoxin conjugated to IC green. It does require a different IC green package than what you're used to for vascular studies with a microscope, but it does allow overlay in white light, unlike the 5-ALA packages currently. It is still experimental. It was originally trialed for pediatric gliomas. It's actually been approved for non-central nervous system tumors, and they're working on an industry-sponsored study to get labeling for adult glioma. So just to refresh everybody on how these things work, so 5-ALA is a precursor to protoporphyrin 9. This accumulates in glioma cells due to the fact that glioma cells have reduced ferrochelatase activity, so they stop the enzyme pathway right before the final conversion from protoporphyrin to porphyrin. This has an emission range in the red-pink spectrum, as we saw, great for high-grade gliomas, about 85 to 90% sensitive and 70 to 90% specific, and it depends if you're looking at the core of the tumor or you're looking at the margin. Sodium fluorescein, as I mentioned, is a blood pool agent, excites in the yellow-green spectrum, only about 84% sensitive and 91% specific, and I would say that the specificity improves the more you use it and the more you get used to how to interpret it. And then tozulercetide, that's scorpion venom is what it is. Chlorotoxin is scorpion venom. So this is a cell surface binding agent. It will bind specifically to matrix metalloprotein 2 and annexin A2 receptors on glioma cells. It emits in the near infrared range and still experimental, but about 87% sensitive in phase 1 trials. The nice thing about these agents is that their emission spectra are non-overlapping, which means you can use more than one of these agents in the same case. And I have done that before, primarily with ALA and fluorescein. Moving beyond the visible spectrum, Raman spectroscopy has been around for a long time. Raman and Krishnan described this phenomenon back in 1928, but it's taken over a century, pretty much, for the technology to catch up. So this uses an excitation laser probe at 2 different wavelengths and takes advantage of the fact that some of that laser light will be reflected back in an inelastic fashion, meaning that its wavelength will change based on chromophore characteristics within the tissue. So this is label-free. You don't need the patient to be injected with anything for this to work. It's primarily utilized ex vivo on samples that are taken directly from the operative field to a scanner. They are developing devices that can do in vivo, in situ Raman SPECT. But basically, what this does is uses this excitation phenomenon and this sort of molecular fingerprinting of the tissue, and then the computer can reconstruct a virtual H&E image. And so what you see on the left is a virtual H&E and virtual immunostain compared to a control. And it's virtually identical, so much so that the pathologists can read it, but more importantly, so can the machines. So with machine learning AI algorithms, this can process the tissue in real time, interpret it in real time, and in about 30 seconds, give you a 98% sensitive and almost 95% specific result. Not only that it is tumor, but the actual molecular subtype of glioma that it is. There are 2 or 3 commercially available products on the market, and there's a consortium that's currently studying this that's based out of UCSF and NYU. Hyperspectral imaging, so this is using information beyond the visible spectrum. The idea here is that instead of capturing visible information, we're splitting up into quanta of nearly continuous spectra, starting at near infrared and going to near ultraviolet. And for each pixel of data, you're collecting a hypercube of voxels across that spectrum. And similar to Raman SPECT, there's a molecular fingerprint that depends on the chromophores in the tissue and which wavelengths get absorbed and which ones get reflected. The difference is that this just uses white light. It doesn't require excitation from a laser. Moreover, it can not only distinguish tumor from non-tumor tissue, it can distinguish ischemic tissue from viable tissue intraoperatively, and it provides wide field macroscopic visualization of the operative field. So as you can see here, this is the white light visible, and this is the hyperspectral analysis showing areas that are consistent with tumor. This is about 88% sensitive, but 100% specific in our early glioma trials. The intelligent knife is a pseudo product name for an intraop mass spectrometer that combines a rapid evaporative ionization mass spect, which basically means that it's using a smoke evacuator on your bovie or your suction bipolar to aspirate smoke as tissue is coagulated and running mass spect on the ionized tissue. So it's this big refrigerator-sized box that sits behind the field that's connected to you, but it has greater than 95% accuracy for identifying tissue while you're resecting it. So this is a great opportunity for real-time margin analysis, and it's been studied in brain, breast, and colorectal surgery. The only thing I'm going to say about augmented reality, which is a topic in and of itself, is that this is where I think augmented reality is really going to make an impact. So being able to overlay, whether it's quantitative spectroscopy, hyperspectral imaging, mass spect, that data on what you're seeing in your operative field is where it's all going to come together to give us feedback that we need for real-time surgery. Very briefly, the last part, we're going to pivot a little bit and talk about intraop therapy options. Anybody know who this is? This is a harder one. This is Malcolm Stevens and his lab group. That's the team that developed temozolomide. So things that are on the market now, we're going to hear later today about GammaTile from Dr. McDermott. We're going to hear a little bit about LIT later today from Dr. Barnett. Gliadel wafers is an old story. That's what's here. That's not what I'm excited about. The 2 things I am excited about, one is photodynamic therapy for infiltrative tumors. So this is taking 5-ALA visualization to the next level and turning it into intraoperative treatment. So this uses a second generation prodrug that is activated with near-infrared light to create reactive oxygen species within the surrounding tissue. So the idea here is that you give ALA to the patient ahead of time. You can use this agent for fluorescence visualization just like you would with glialan. But then when you're done with your resection, you can bring in this red-emitting near-infrared probe that will create reactive oxygen species within the tumor cavity and treat residual microscopic disease that you may not have resected. Near-infrared penetrates about 1 centimeter beyond the source, and it is entirely dependent on drug uptake by tumor cells. Currently only available as part of an industry-sponsored trial based out at UPMC with Dr. Hadjipanayas. Lastly, in terms of intraoperative treatment options is focal intraoperative radiotherapy. So instead of having to finish your case, wait anywhere from 2 to 6 weeks for them to start their radiation treatment, you start it intraoperatively. This is a low energy 50 kV emission device, basically has different ball tip probes at the end of it that allow you to deliver anywhere from 20 to 30 gray radially around the cavity with about a 2 millimeter penetration to the depth of it. This has been studied in Europe. The Intrago 1 and 2 trials looked at using this for newly diagnosed glioma. Intrago is the phase 3 trial. They've finished recruitment. They have not released any preliminary data yet. Intramet is the study that was announced, the results were announced at ASCO in 2023, looking at using this for treating the cavity after resection of a cerebral metastasis. That study was halted prematurely because of favorable outcomes at the interim analysis. They were intended to recruit 50 people. They only recruited 35. They had a local control rate of almost 95% and a remote control rate, meaning no secondary or satellite metastases, at almost 60%, which is almost identical to stereotactic adjuvant radiosurgery. So in summary, next 5 years, maybe 10, going to be super exciting as far as I'm concerned in terms of being able to revolutionize how we do surgery compared to even what we're doing today at the cutting edge. Thank you.